નથી આવતો સર વાત કરે છે
સ્કેન સ્ટાર્ટ કરો
નહીં સર વાત કરે છે અવાજ આવે
Hello.
કરો સ્ટાર્ટ
Hello, can you hear me?
વેરી સ્લો
Hello, can you hear me now?
યસ વી કેન હિયર યુ બટ વોઇસ ઇઝ લિટલ લોઅર
તો ત્યાંથી વધારજો
ત્યાંથી વોલ્યુમ વધારો.
નાવ ઇટ્સ ઓકે
It's okay?
ઓકે
Okay. So we are going to look at the scans first.
યસ
You have the scans? Scan che?
નો વી હેવ એક્સટર્નલ પિક્ચર
Okay, we'll switch to scans.
યસ
ચાલુ કરજો. ફોન કરજો. Okay?
યસ નાવ પિક્ચર
Okay, so let's look at the MRI first.
યસ સર
So we are starting with the cuts from anterior or whatever is there anteriorly. So
Okay.
you have the turbinates, inferior, middle and superior, nasal septum, the orbit. As we go back, sphenoids and come into the sphenoid.
યસ સર
We will not pay too much attention here because we are going to see the same sinuses on a CT.
રાઈટ
Okay, so we have now optic nerves running across. We are So now we are fully in the sphenoid sinus. Above is the anterior cerebral circulation. Laterally of the middle cerebral.
યસ સર
In the center is the intersphenoid septum.
રાઈટ
And you start seeing a little bit of the tumor here.
રાઈટ
As we go further back, you see more of the carotids now.
યસ
here.
સર
And you see the tumor here. Okay, so that's
Yeah.
an enlarged cella with what looks like a pituitary adenoma.
રાઈટ
And that's the end of the carotids on this scan. Now, when we are looking at these scans, there are a few things that we want to see. Right? One is the size of the tumor,
યસ
whether
સર
it is going supracellular or paracellular, whether there is invasion of the cavernous sinus or encasement of the carotid glands. We also want to see if the optic chiasm is getting tented up. So you see the optic chiasm here?
યસ સર
There is slightly tenting. So we would expect some bilateral hemianopia in this patient. Somebody will give us the history at the end of this.
યસ સર
And we of course will look at the anatomy. Now the other thing we want to see on a scan is where is the normal pituitary.
રાઈટ સર
Okay? Now this is the Sag cuts. So what the Sag cuts tell us are two very important things. Shit, this is not such a good scan. Okay, this is better. Okay. So what this sagittal scan tells us basically is the pneumatization of the sphenoid. And if it is a precellar or a conchal, then you want one of those cases where you might want to keep navigation. For conchal, 100%, and for precellar, advisable.
યસ
For this kind of pneumatization, very clear cut, absolutely no problem.
ઓકે
You're also looking at this planum line and seeing how much of it is supracellular. If the lie of the tumor is going posteriorly or anteriorly, or if it is going straight up.
ઓકે
So when the tumor goes posterior direction, it's favorable because our approach is from here.
ઓકે
So it becomes easier. When the tumor extends anteriorly, it becomes more difficult because like operating on a frontal sinus.
રાઈટ
So then you have to take out a little bit of the tuberculum and even a little bit of the planum.
રાઈટ
For us, this looks all right. Okay?
ઓકે
Now, if you see again on this, you see this is a contrast scan. So you see a little peripheral enhancement, which would tell us that this is the normal pituitary splayed out, with the posterior pituitary at the back. Okay?
Nishit,
This is
can you see the
stalk area?
stock?
Yeah, this is the stalk area,
Yeah.
which we'll see maybe with a coronal we might see better. So these are coronal contrast scans. You see the stalk now? Okay?
Yes.
So we have more normal pit on the right side than the left. Okay, though it's touching the carotids,
Yes.
it's not crossing the midline. Okay,
Right, sir.
so it's not gone yet into a 3, maybe just a 2 yet. Okay, and then
Nishit, what are you able to say about the consistency of this tumor?
consistency, if it looks bright and little more mottled, I'm going to say it's soft. In this case, even on, let me see a T2. Even on T1, T2 is not looking very bright. So it may not be very soft, but these are judgments. These are not predictable. It's often you're right, often you're wrong. And then you want to look at the axial as well. And axial gives you a much better picture of the lie of the carotids in relation to the tumor. So you see now very nicely the carotids on both sides with the cavernous and the tumor. So slight impingement on the left side, but nothing very significant. Okay?
Yeah,
And that's your stalk at the back.
that's a basilar.
That's the basilar. Sorry, you're right. Basilar. Where is the stalk?
Yeah,
Not
that's
able
the
to
stalk. That's the stalk. Right on the top there. Just one more, yeah.
Yes.
Not very happy with it.
Right on the top of the tumor. Yeah, that's fine.
Maybe, yeah. Maybe that might be the stalk. So you can follow it back actually towards the third ventricle. Okay. So here you also have the anatomy quite nice. Okay. Let's look at the CT scans so that we get a good idea of anatomy. So slightly deviated septum, but not looking too bad. Sinuses are really clear, little bit in osteomeatal. Antibiotics have been given, so we should be okay. Superior turbinates coming up, no concabullosas. Posterior ethmoids, pneumatization there at the back. Let's see if it's part of the sphenoid. As we go back, we see it's probably part of the sphenoid. Okay, so that's all sphenoid. Now we may have a cell here. Let's just change this window a little bit. Yeah, okay. So we are seeing that there was another cell up there, right? With this pneumatization.
Yeah, that's quite evident.
So though it seems communicating with the sphenoid, we'll have to be careful because there are incomplete septations there in the upper part. And that will block my view of the optics. So I will be opening the posterior ethmoids in this case. So you can see on the sagittal views that we have these septations coming in here. Right? So I think it will be a good idea to open the posterior ethmoids on both sides. Okay. Okay, any other questions, any suggestions?
So Nishit, the deviation of the septum, will it decide on which side you take a flap?
To some extent, it may. The anterior deviation, of course, will not change. Just trying to see if there's an axial here. Okay, so we are going to be removing the bony septum from here back. So this bit of deviation will improve. Anteriorly, I think we are not too bad. Slight deviation, which is again anchored by the septum cartilage junction. So I think it should improve a bit. We don't need to come more anterior. If there's a very grossly deviated septum, I will take an SMR incision on the side of the flap that we think we are taking, do a septoplasty, and then do rescue flaps.
Right.
I request Dr. Jayesh Patel and Dr. Vedic to chair the session.
In this patient, we are not expecting to have a CSF leak, so we'll at least start with a rescue flap and then convert to Hadar only if we get a leak. Our intersphenoid septum ends on the right carotid, and it's a much smaller right sphenoid. Okay, that's the ostia of the sphenoid on both sides. So it's a little lateral, as you can see on both sides. That's the sphenoethmoidal recess, superior turbinates, middle turbinate, ground lamella, middle turbinate, ground lamella, and this is the uncinate process. Okay, so even when we didn't do it yesterday, but actually when you're reading an actual scan, it tends to give you a lot of information which the other scans don't do. So these are uncinate processes on both sides. Okay. Anything else? Narayan, anything else?
Yeah, I think you've covered everything nicely. Are they ready with the case?
Yeah, patient is induced. We are just still painting, draping, still remaining. So another 10 minutes.
Okay. So if we have to discuss, Nishit, when would you do your ethmorectomies, or when would you do, think of extending your approach laterally? What all were the steps would you think of? I'm not talking of this tumor. I'm talking of when you would do your other approaches, and can you also explain on the scan what is the transtubercular, transplanar approach?
So this is the cella, right? If this tumor in here is extending subfrontally, is coming onto the planum or going very high up, not going posteriorly, then I want to take the tuberculum. We are talking of pituitary, of course. If there is more tumor extension anteriorly, then I will take the planum. If there is an onodi cell or sphenoethmoidal cells, we will open the posterior ethmoids. If I feel that at any point I may even want to consider a transtubercular approach, I will open the ethmoids. So it's not actually difficult to open the posterior ethmoids, because we go in and we'll show you that via the superior meatus. So we don't need to come from anterior via the anterior ethmoids. We just resect the inferior half of the superior turbinate and join the posterior ethmoid with the sphenoid. And this is more commonly done for me on the right side, so that I have a parking space for the endoscope, which will typically sit at about 11 o'clock. So any case which has extension up towards the planum and requires further drilling, you can't do instrumentation unless the scope is at a higher level. And so you have to then open the posterior ethmoids. Inferiorly, of course, if something is going on to clivus, you'll go with the mid clivus, and for chordomas and all, you may go with the lower clivus. It's very rare for a pituitary to go to require a clival approach.
Okay. And if you put on an axial scan, just can you put on the axial MRI scan, any MRI scan? So on this, would you be able to explain the extensions into the cavernous and how you would think about dealing with it? Medial cavernous, lateral cavernous, non-functional tumors.
Okay. So here you can see the carotids on both sides. And you see on the left side, there's a little bit of tumor sort of pushing into the left cavernous. So again, if it's only pushing, not encasing the carotid, your bone removal will be up to cavernous. You don't need to expose the carotid. If it is encasing, even partially encasing the carotid, then you have to drill a little bit of bone over the carotid to expose it. So that when you take your incision on the dura, which is not over the cavernous in a normal situation, but if there is no bone, the dura then becomes a little more pliable, a little more movable, so that you can enter into the cavernous area. Usually when we talk of transposition of carotid or moving the carotid, it doesn't mean you open up the whole carotid area and work in circles around the carotid. It usually means just pushing the carotid a little bit laterally and trying to find the spaces into which the tumor has invaded. Is that what you're asking?
Yes, sir.
Can someone please tell us the history? What complaint the patient has come with? What's the vision?
Hitesh bhai, history શું છે? History?
Yes, this is patient Chotha Bhai. He is come with the complaint of vertigo and headache only.
Catheter.
So he diagnosed with right side mania disease and MRI was done. It was suggestive of there is a anterior-pituitary hypodense, hyperintense nodular lesion with supracellular extension in the optic chiasm, abutting the medial surface of the right internal carotid and posteriorly encasing the left cavernous sinus segment of the left internal carotid. The tumor size is 16 by 9 by 16 by 8 by 15 by 8 millimeters. So it is pituitary macroadenoma.
So basically an incidental oma.
Incidental, yeah.
So the hormonal
Patient come for
assays,
complaint of vertigo.
hormonal assays are normal,
Hormones normal. Yeah.
and the perimetry?
Vision.
Vision is normal.
No, perimetry.
They are saying normal only.
So on the perimetry there is slight field effects laterally, but it's not too bad. Vision is normal. With further pushing into the cavernous nerve, then you will get involvement of your third, fourth and sixth nerves. But initially it is peripheral vision that is affected, and only then you get little blurring, and then you will get other cranial nerves involved. Headache is common now. It's debatable whether we want to operate on this patient or observe, since it's an incidental finding.
Yes, sir.
With normal hormonal assays. One option is to do regular MRIs every 2 years and see for growth. The only counter to operating is that there should not be an apoplexy. So when you have a tumor and if there's a sudden bleed in the tumor, it will swell up and can cause have serious consequences. So all these points have to be given to the patient, and then in consultation with the patient, we can decide whether we want to operate or observe.
In case the patient has already developed some visual field defects, what prognosis are you going to give to the patient after surgery?
In case the patient has,
Visual
loss.
defects?
Already vision started affecting.
yeah, so if it's not loss of vision, then you would expect vision to recover.
How soon, sir?
So it depends on how old the problem has been. We have had patients who feel better the same day of surgery, and some will take a few weeks to get better. Okay. So we are still doing the catheterization and prepping for the thigh and all that. Now it's very important for us to catheterize because we have to monitor urine output. There is, in any pituitary, a potential for little stimulation of the stalk, and that can result in a DI. So if you get diabetes insipidus, then you will get a sudden outpouring of urine, and that will affect your electrolytes. And these things can go undetected if you are not careful. The patient is drowsy and you're not sure what is happening. You think it's post-op anesthesia. And these things can have, catastrophic consequences. So monitoring the patient post-op for electrolytes, especially sodium, is very important.
And video anesthetists always take a central line, sir, or they'll do with the peripherals?
Yeah, for this kind of tumor, I don't think we need a central line. If it's an extended approach, extended surgery, if you feel the carotid is at risk, there's a high chance of bleeding only then.
Okay.
So the question is, in case of DI, what is more effective? The most effective treatment for DI is to call an endocrinologist and let them handle it. That's why, pituitary, though it looks like a simple surgery, is not necessarily a simple surgery. And you must have your full team, which means intensive care, intensivist, neuroanesthetist, endocrinologist, ophthalmologist, and of course ENT and neurosurgeon. I think these are why, and your interventional radiologist. I think these 6, can you hear me? Hello?
One of the most important things, if I can put a point is, all our patients,
Hello?
all these patients
Hello?
overnight into the ICU. It's just a standard route.
Hello?
Yeah, Nishit, we can hear you.
Yeah, so
Nishit.
the entire team, I don't know if you heard that.
No, we missed it, but I was bringing out another point to them.
Okay.
That all our patients of pituitaries, acoustics, problem or no problem, once you've breached the or you're doing these skull-based cases, they go overnight to the ICU. Okay? And maybe next day morning we can take them off the ICU. In pituitary, it's most important to identify your diuresis that takes place. So you need to measure your urine output per hour. You do a most fantastic surgery, and if you still have diuresis in this patient, you're going to have a lot of sodium loss that is going to cause hypotension, and that is also responsible for brainstem infarct. So don't take that diuresis very lightly. It's a very serious problem, and you have to deal with it quite effectively. So one night in the ICU, and then next day we take the patient out. Okay? And again, use of lumbar drains versus no use of lumbar drains. By and large, no use of lumbar drains in these cases. Some people like to keep a lumbar drain in, and if not necessary after the surgery, take it off or whatever, maybe put it later. But by and large, no use of lumbar drain. Nishit, do you want to add anything onto that specifically?
No. I was just saying that the team is very important. That's why, how do you treat DI best is to call an endocrinologist, is to have an endocrino on the team. Not try and do these things on your own.
Nishit.
Even still, yeah, you can't hear me, I suppose.
Yeah, I can hear you. There's a question for you. What is the contraindication for doing a transsphenoidal pituitary in terms of sphenoid anatomy?
So initially it used to be a conchal pneumatization of the sphenoid. I think today if you have a navigation system, there is no contraindication. For a sphenoid anatomy, no? That's the question.
Yes.
Yeah, for sphenoid anatomy. Intracranially, if there is a large paracellular component is going into areas where you have to cross a nerve, then you may consider going transcranial. But purely from a sphenoid anatomy, nothing.
I welcome our neurosurgeon, Dr. Milan Makwana.
Just say.
Please, sir, you are invited to moderate the session as well.
Also, the other thing you must remember is when you have cavernous or carotid invasion, and if you have essentially a non-secretory tumor without significant cranial nerve palsies, then you don't want to chase it too much into the cavernous sinus. If it's soft and it's suckable and it comes out easily, so be it. But you're not being aggressive with tumors going into cavernous sinus unless the cranial nerves are already involved or it's a secretory tumor, which means Cushing's or growth hormone. Then you're going to be aggressive. Otherwise, you leave whatever is residual for radiotherapy.
Sir, during intraoperative procedure, how often do you send the sample for the frozen section?
For pituitary, no, not really. Unless there's a doubt about diagnosis. So that happens sometimes with hypophysitis, granulomas, which are mimic pituitary adenomas. Take a minute, I'll just give position. Too much
Sir,
extent.
suppose there is problem with the pre-operative blood reports and pituitary hormonal profile. How much time do you take to operate and delay the procedure
Or then.
before giving any medical treatment or what?
देखो लो वो लो पिलो देखो.
See, the answer to that is every patient of pituitary macroadenoma is examined by an endocrinologist. It is the endocrinologist who tells us good time to operate. We don't rack our brains about it. If the hormonal profile is normal, we operate these patients primarily
Yeah,
for
heart
visual
means it, yeah.
disturbances. Okay, and most of the tumors are non-functional. So the hormonal profile is generally normal. The problem comes in prolactin high levels. Okay, so if you have high prolactin levels, the treatment is basically bromocriptine. And when you give medical treatment, most of these tumors regress. It's very rarely that you have to operate a prolactinoma
Painting is not done, I think.
which has not responded to bromocriptine.
हाँ, do painting
And
first,
then
then
in
do.
those cases, your
Alternate.
tumor is very firm and fibrous. So you have to take a lot of care that this tumor is
Tablespoon
not
down.
just going to come down very easily. Okay, most of the other tumors are fine. In functional tumors, it becomes different, like acromegaly, Cushing's, etc. Those tumors are completely different. Now, in acromegaly, if I could, Nishit, I'm just pointing out some differences in acromegaly.
Yeah,
In
I'm just going to wash up, so
Yeah,
you
exactly.
carry
I know
on.
you're going to wash up. That's why I'm taking over.
मेरा mic बंद करो.
In acromegaly,
बंद करो.
these patients have a very, very big profile, like growth hormone, etc. So they have very wide nostrils. Their mucosa could be very edematous. Their bones will be very strong. Like if you see Nishit doing in this case, he will first take the medialize the inferior turbinate, push it, right? So we can easily fracture the turbinates. In acromegaly patients, it's very difficult to move these turbinates laterally. It's very difficult to do that. Same way when you start taking off the sella, you'll find the bone is very thick. In most of these patients, sella is very thinned out. But in an acromegaly patient, very thick. The acromegalic patients would have very tortuous or big carotids. So you have to be careful about that. So when you're going between the carotids, you have to be very careful that the carotids are not going to prolapse back into your field. Okay. The other thing is that even in acromegalic, they are used to aneurysms. You get intracranial or other aneurysms. So you have to make sure that when you're doing a scan, you have to make sure that the carotid does not have an aneurysm, because that could burst during the time of surgery and you'll be in deep mess. So you have to understand and remember all these factors. And for growth hormone or Cushing's, whatever it is, they are functional tumors. So in these cases, we are going for total removal. So whether it's in the medial cavernous, lateral cavernous, etc., we have to try and get the complete excision. Okay, unlike non-functional tumors where we don't venture into the lateral compartment. Okay, in these acromegalic tumors, we try for total removal. Sometimes it's not easy, but idea is not to open a separate compartment laterally. You have to try and open up from medial, follow where the tumor has gone into the lateral compartment and then take it out from there. So follow the natural course of the disease. Okay, a natural extension, I would say. The more important thing is that all these patients of functional tumors, we have to do an intraoperative MRI, which then decides whether we have done a complete job or no. Right? We can't send these patients back. This thing is echoing quite a bit here. इको बहुत हो रहा है तो वही डिस्टर्ब कर रहा है. मैं मेरा ही खुद का आवाज सुन के परेशान हो रहा हूँ. So the idea is in these acromegalic tumors, okay, so what we do in our institute is we don't have an intraoperative MRI, but what we do is we do the surgery, try to get some amount of hemostasis going, keep patties in the nose, and then from there we take the patient down to the MRI suite, do an intraoperative MRI, contrast given, and a dynamic MRI scan, and
Hello?
ensure that the
Praise?
the tumor is totally removed. If
Hello?
the MRI there is some remnant tumor left, we take it back, complete the surgery,
Hello?
complete hemostasis and nasal patch. Okay? Ideally, yeah, with the patient intubated, we take them down to the MRI.
Hello?
Then,
Hello?
Hello.
Praise?
Yes.
Dr. Milanbhai.
Dr. Milanbhai just arrived.
હા
Here you.
અહીંયા ઓટીમાં મોકલી આપો. Hello?
He is coming.
Okay.
So there are anatomical differences when you have patients of acromegaly. You have to remember all these.
You have to remember these anatomical differences whenever these patients are there. They're not like the usual non-functional tumors where everything is plain and simple and you go in and do the surgeries. In acromegaly, you will get a lot of congested. Even when you're stripping the sinus, sphenoid sinus mucosa, you'll get a lot of oozing in these acromegalic patients because the mucosa is very edematous. Okay, bones are very thick. You have to note all these features of acromegalic patients.
Sir, at the most of the center, we do not have intraoperative MRI facility. So after post-operative, how many days you send the patient for MRI?
After post-operative?
Post-operative.
Post-operative, not before 3 months. You're not going to get anything by doing an MRI in 1 week.
Okay, sir.
It takes 3 months for all the blood and blood products to get absorbed and you to get a clear picture. Till then, you're only guessing what is remnant tumor and what is the blood product. So it has to be a minimum period of 3 months. Even if I see a residual tumor at 10 days or 15 days, what am I going to do? Nothing. Okay. Siam used to help when we used to have a problem in the earth. Yeah. So Siam was used in those days when they used to use a microscope to make sure that they're going into the cella. They used to keep an instrument from here, take a Siam and make sure that we are into the cella or into the sphenoid sinus or we are hitting the cella. That was the days of the microscopic era. Today in endoscopic era, we don't use Siam at all because we know exactly where the cella is. No, not at all. It will only give you bony anatomy. So it just tells you that you're on the cella. Technique is the same, but you have to run after total removal and functional. In acromegaly patients, when you operate these patients, it takes a while for the growth hormone levels to come down, or even quickly for that matter, on the levels to come down. But acromegaly patients, immediately you see their face brightening up. It may take a long time for the fingers and legs and all that.
Coach, maybe you go opposite so Hitesh, I can help from here.
Start looking even somewhat normal.
Oh, you will go opposite? Okay, some में आओ.
Just make a lot of white.
Lefty छोड़ता मैं.
First thing you can see is a dark look. That you notice.
Okay. Can we turn the table towards me? Put the table मेरे बाजू turn करना.
So if they ask us, many times in conferences, in panel discussions, we are asked, what is Hello?
हाँ.
Nishit, we are with you.
Yeah, tell me.
No, nothing. We were just discussing because you were offline.
नहीं आप head up करें, head नीचे करो. नहीं वो नीचे करो पहले.
Nishit, there was a question. Would you use navigation?
बस. अभी
In any case?
turn. Yes, if we have a poor pneumatization of the sphenoid, if we have any extended approach, नहीं turn करने का. Any extended approach, or if it's a revision surgery.
Right. Not in routine cases.
No, not routine, not for pituitary.
But
Because-
is carotid more important than navigation?
Bas. Doppler is the only real-time navigator,
Correct.
so more important. Chalo, let's get the packing, please.
Can we have the endoscopic picture?
No, not yet. Sterile che? Nahi. I'm just packing the nose, then we'll take the scope. Abhi ja.
Was a Doppler. More important is Doppler rather than navigation. Okay? Doppler probe, yeah. Cheaper but more important than navigation. And for all these cases, like for all our nasal cases, we don't really
Orthoven nathi,
inject
huh?
anywhere. We just try to put
मैंने orthoven डाला हुआ.
Merosil soaked in adrenaline and diluted with adrenaline.
You put yourself.
Dilute adrenaline patties or
put
Merosil
yourself
pack.
onto it.
We take it and keep it in the nose.
Want some
10
more?
minutes is what we look at.
Not enough. Just put on these.
I already asked this question to know whether the pituitary tumor is hard and soft in MRI. Is it easily resectable? And ask about reconstruction of skull base defects. So there's a question over here. reconstruction of skull base defect. Nishit, you want to talk about it?
Yeah, I'm
What-
just setting up. You continue. I'm listening to you.
Okay. So for reconstruction of skull base defect, in all these pituitaries, like Nishit has already told you, we are not expecting a CSF leak. In most pituitaries, unless they are pushing very high on the diaphragm, we are not likely to get a CSF leak, okay?
Light band kar se.
So what we follow is the technique of preserving rescue flaps. So Nishit will show you what are rescue flaps on both sides, and we just preserve the pedicles. That is the posterior nasoseptal branch of the sphenoid.
That's okay, also
we
that
preserve that. Going towards the septum, we preserve those two pedicles on both sides, take it down before we resect the rostrum of the sphenoid and take the whole sphenoid to its flow. Okay, so Nishit will show you that. That is all that we do. If we have a CSF leak post-surgery, then there are different ways of dealing with it. If it's a very tiny rent, just take a little fat and put it on it, that suffices. Okay? Just a little fat, you don't need a Hadad flap. But if you have a bigger rent, then the same rescue incisions, you can extend it forward as Nishit will show, and then you can use that Hadad flap for over that whole area. Again, Hadad flap cannot be used directly on the sella. You have to use the first layer, which would be fat, and then over that you have to use the Hadad flap. So you see what we do, what even Nishit will show you is, he's got the endoscopic picture. Nishit, you want to start off?
Yeah, so you can see the turbinates are still quite thick, and the septum looks a lot worse than we thought it can. This is the first look. So let's see, I'm going to try and decongest this inferior turbinate a little bit more before I take a call on any septum. What's his name? So just to welcome Dr. Milan, who is our neurosurgeon. I would strongly suggest that we don't do this surgery without a team approach of ENT and neurosurgeon. So always the neurosurgeon is in the theater with us. Which was the other one? This? You put Otrivin on all? No. Otrivin was on which one?
Yeah, the one you packed now.
No, I took only one.
Yeah, and then this one.
Okay.
These are the three ones.
There's a concha bullosa
Nishit,
on the
Nishit.
scan. Vaibhav, just check if there's a concha bullosa. Bol.
there is, your picture is very well focused, but maybe 1% more. See the periphery, you'll understand.
Sukeche, I didn't hear.
Focus.
You want focus better?
It is good, very good.
Huh?
Maybe 1-2% you could improve it. Yesterday you were saying, na?
Yeah, I can improve 1-2%. Okay. No concha? Okay, is that better?
Yeah, focus.
So though it looked like a concha bullosa here, on the scan we're not getting a concha, and we actually saw that there was no concha. But when you look inside, it looks very typically like a concha. Right? So this creates a little problem for us. Okay. Chalo. Give me an elevator, please. Suction. Elevator, please. Okay, so let's see what kind of space we can manufacture.
Yeah, so Nishit, can you explain why this maneuver is done?
So we want most of the trauma not to happen on this external surface. By fracturing that turbinate, this lateralization becomes a little easier. And if it bleeds internally in the inferior meatus, it doesn't trouble me. So I hope we have the right patient scans. If this turbinate is troubling us too much, we'll take it out, okay?
Yeah, it looks very bulby.
Very bulky, yeah. Okay. So when you are lateralizing, typically you want to go at the back end of that turbinate. Just where you have the superior turbinate, and here I'm going to take the superior turbinate with me. Give me
So
your
one thing
packing.
is when he's lateralizing the middle turbinate, you can see he's going along the posterior aspect of the horizontal limb. He's not lateralizing it on the anterior attachment. Okay, if you do that, you're going to get a CSF leak right at the beginning of your surgery.
Narayan, you have a laser pointer?
I don't know.
Maybe you can ask them, then it'll be easier for you.
So as you're seeing Nishit doing it, this is a very important thing. You have to lateralize your turbinate very gently and keep putting in these merocyl patties or your neuropatties soaked in adrenaline. Just keep pushing it, and that gradually sort of widens the space up. Okay, initially the space appears quite restricted, but as you keep doing this maneuver, you see him putting more and more number of patties over there. Those patties gradually enlarge, cause the decongestion, and improves the access and space in that area. So you have to take your time in the beginning of your surgery. If you rush for a surgery, it's never going to work.
And that doesn't matter because we don't have raw surfaces on either side. So we'll get signing here if there is two surfaces. Let's have a look at this side and see what we can do. So now we've decongested this IT, it's looking a little better. Elevator. Elevator. So again, don't use the tip of this instrument, use the shaft of the instrument when you're doing this. And here also I say I'm not using the tip so much, I'm using more the shaft. And I'm just running at the back, at the upper part of the turbinate. Okay, maybe we are not so bad after all. So on this side, you see, you have to try and find, there's always a little shoulder, there's always a little part which, when you move, everything suddenly moves away. So now you see the superior turbinate, suction. Okay, so we have a view of a superior turbinate at the back.
Yeah, quite well seen.
Okay, so we can continue with the lateralization. Find the ostium is it's always in the inferior half of the turbinates. You never go in the upper half. You go in the upper half, you're going to get trauma in a very narrow area, which is then in blood on your scope and get you frustrated, and then potentially increase the risk of a CSF leak. So always stay inferiorly. Further lateralization in the superior part will be generally only after I find the ostium or with patties, if I feel that it's not enough. Catheter, catheter. So as you go back, then you go a little laterally. So I go along the septum and then just at the back I'll push little laterally. So we're trying to open up that sphenoid recess. And once you feel you're confident of that part, then you can also pack a little bit superiorly just to get maximum lateralization of the MT as well. Okay, but that's a soft lateralization.
So if anyone has any questions, yes. Which is that? No. Nishit, there's a question from the audience for you. Which is the common artery associated with apoplexy, it seems? Okay? When it bleeds.
I don't think there's an answer to that.
Yes, exactly. Okay, I'll try to answer that.
It's just a
Nishit,
tumor
I think
bleed.
I should say. Apoplexy happens from intratumoral hemorrhages, not from an artery. No inferior hypophyseal, no superior hypophyseal, okay? It happens from the tumor itself.
Very big.
The tumor contains a little vascularity and suddenly that bleeds and you get a little bit of collection in the sella, which increases the size of sella and causes like a medical emergency because it pushes up on the optic chiasm. Apoplexy is also known if you leave behind residual tumor. Okay, you have done a surgery, you have left behind a chunk of tumor and the tumor suddenly bleeds because all the end arteries, end capillaries are open. So it bleeds suddenly, and if your sella is not open, instead of coming out, it gets accumulated there. That becomes emergency
Does it have
where
a
patient
side
is in
hole
the
or it's
ICU or
only a
next day
front
patient
hole?
says, I lost my vision. Then those patients you have to immediately rush down.
No. Just lift this KT, put in the center, take out the packing forceps. Put the catheter in the center. Now put the KT. Yeah. So I put a little catheter in the nasopharynx. And that's just to suck away the smoke when we are doing our flaps. Okay, so the first thing to check is whether we have enough exposure. How many patties in here? 2 patties. 2 patties. 3 patties. 4 patties. Finished? Okay, so now we have a good view of the sphenoid anterior wall with ostium. So we can start with our rescue flaps. Give me the cutter. Mane hath mein aapko. Direct. When I tell you cutting is on how much? Cautery cutting કેટલાનું છે? Monopolar. Patient foot pad છે? Narayan, do they know the difference between rescue and Haddad?
Pardon?
Do they know the difference between rescue and Haddad?
Yeah, go on, you can show them because theory is different from practical. You'd have to show them there.
So in a rescue flap, incomplete Haddad flap, our incision will start right at the back over this is the eustachian tube. So just over the eustachian tube, we will come across, leave a little tiny bridge of mucosa there, come right here. Now if I have a very wide sella, I will come onto the floor and then come anterior. In this case, I don't have a very wide sella, so I'll stay at the lower part of the septum. My incision will stop at that cartilage bone junction, which is formed by this ridge, okay, which corresponds more or less to the anterior part of the middle turbinate. My superior incision, and this you can see very nicely here, you see blood vessels running horizontally. Is that clear on your screen?
Yeah, we can see it quite clearly.
And here you see the oblique.
Yeah.
Okay, also this is more yellowish, this is more pinkish.
Yes.
Okay? This tells me where my olfaction ends and I'm safe to take my incision. So I have to take my incision on the horizontal fibers, not on the oblique fibers, though I may start at the level of the ostium. I don't want to start an incision here, and I don't want to start this incision here, which is again a common mistake people make.
Yes,
Though you
absolutely.
get the pedicle of the flap in this, The wider the flap, better the blood flow, blood supplies, because you also have a couple of secondary vessels. And more important, a thin pedicle can twist and suffocate the flap. So always have a wide pedicle. Okay?
Absolutely.
Third is you see these tiny ridges. These are formed by olfactory fibers. So my incision up will come here, and then I'll go down, stay at this horizontal level, and come all the way, till here. Okay?
Yes.
If I were to do a hadad, I would continue in an upward direction, because now there's no olfaction. Come all the way anterior till the mucocutaneous junction and down to join it with the inferior incision.
Right.
The advantage of rescue is at the end of surgery, we just close if there's no leak. If there is a leak, we extend the incisions anteriorly and it becomes a hadad.
Right.
Okay, give me a suction, just give a clear view of this blood. Okay. Kitla pach hai monopolar?
20.
20. What is it? Esculap? What cautery machine is this? There are 30 karne, 30, 35. Cutting 35, coag 30. Okay, let's see how effective it is. Cutting. No, not working. Patient foot plate છે? On. No, not working. 45 करो. On. Not working. Off. Just give me artery check. Artery check, artery. So we're just waiting for our cautery to work. This same rescue incision will take on both sides. There are days when I have a small leak, and if I want, I can do what I call a mini flap, which means my two rescue incisions, I will just join it over here instead of coming all the way anterior, and use a shorter flap from laterally, not from the floor, to close the defect. Advantage, I don't have any cartilage exposed. I don't need to put a splint in. If I do a hadad at the end of the surgery, then I will not do a reverse flap. If I do a hadad at the start of the surgery, I will do a reverse flap. A reverse flap is basically the same incisions as a rescue flap, but I will take an additional incision posteriorly from here up here. Okay? So I will disconnect the artery from the flap, which will be pedicled, broad pedicle anteriorly. This flap will then rotate, go on to the opposite side and cover the cartilage of the hadad side. Is that clear? All the four different flaps?
Yes, sir. Yes, sir.
Okay, let us see if this. Let's see if this cautery works. On. Keep on. Don't release. So don't release. Stay on. So I want to be sure I'm on bone before I start moving across. Often you can get a small pharyngeal vessel here off. So the person who's doing the cautery, I have to remind them to look at the cautery and not at the screen.
So this is Colorado. Which one is this?
Yeah, this is a Colorado, long Colorado with a bent tip.
Bent tip.
Off. So I will try and see where I need to end. So this is my approximate superior incision. So I'm okay here. Over here is my terminal branch of the greater palatine. So when you're doing like a septal perforation, that's your pedicle flap, greater palatine. Or you're doing a big hadad, it will bleed from here. So I don't want to extend till here if I'm doing a rescue. My upper incision on, I'm also going to take a small short lateral incision onto the superior turbinate, and this helps me lower my flap better off. Otherwise this flap doesn't come down as well as I want it to on. So I'll start at that level of the ostium, and then I will go down to our level of our horizontal fibers. Off. As I come anteriorly, I just want to see again till where I need to stop on, and I will gradually again start curving upward. Off. So here I am at the, hopefully at the cartilage bone junction. All right, this is my rescue incision, elevator. I can elevate now, I can elevate later, not a problem. On my other side, you saw there's a very sharp spur. So this side I want to be careful with my elevation, because I'll probably use this side as my Haddad side, should I need to use it.
Nishit,
Huh.
the picture is appearing a little red and dark all of a sudden. Do you want to do white balance or maybe give it a wash?
Okay. We have actually a very nice picture here.
Okay, it just appeared red over here.
Maybe your color
No, we
balance on your, okay, maybe this will work better now, you think?
Now
Better?
it's better.
Better now?
Yeah, very
Wash.
much better.
Wash. Imne ja, wash. Suction up. We'll give a wash also. Okay. Okay, fine. Bas. Okay. So we'll just elevate that superior incision as well. So that incision you have to make sure that it's sort of right up to the bone or cartilage, because otherwise the periosteum stays intact, it tends to bleed. So now we're at the level of the ostium, and I want to just elevate the other side also a little bit. So we have some connection there with the mucosa of the sphenoid. Inferiorly, our end point is the palatovaginal. Okay. Give me a ethmoid for a sec. Holding. Ethmoid. I'm just going to see if I can disconnect the mucosa from the flap. Okay. Holding. Okay, so now you see how that little lateral extension helps us, because it allows my flap to come down a little easier.
Yeah, very nicely seen.
Okay, and then here we are going to be now close to the palatovaginal. So if I have a suction, I'll show it to you. Okay.
Yes.
Palatovaginal.
Yes.
Nice clear cut cap. Not always you get a clear canal like this, but today we have a very nice canal. Ball probe. नहीं वो छोटा स्ट्रेट बॉल था ना, अभी नया इंस्ट्रूमेंट दिया ना, एक 5-6 इंस्ट्रूमेंट नहीं, स्ट्रेट बॉल प्रो ऐसा एक, हाँ उसमें होगा देखो. So I just want to maximize my incision. थोड़ा वेट करें आपको. So I'm just going to elevate all the way anteriorly till my incisions. So I'm just using this little ball to come anterior. Okay, so this completes our elevation of the rescue flap on the left. Okay, we have to do the same thing now on the right side.
Yeah.
Packing. I'm just going to put a patty in here to protect my middle turbinate when I cut from the other side, because sometimes you cut through and through, and then you don't want to cut the or burn the turbinate. Okay. My catheter will change to this side. Again, you saw how it works to prevent the smoke from interfering with your vision. Okay, fix. Let's hope we have some clarity on this side. Finished? 3 only? I am keeping count. Okay, elevator please. So I need a little better vision here.
Nishit, at this point in time, you can also tell them what is a reverse flap.
Yeah, so I already did that, I think. I don't know. But I'll show it to them again. Okay, so just a little bit more of that part I needed to, so I can see my ostium better. Okay?
Yeah.
Suction. So you see I already have a little marker here from my opposite side.
Absolutely.
So that's good. I know exactly what level to go at. And despite that DNS, now I think we are okay.
Absolutely.
Butter. On. Off. On. Off. Don't worry about my hand. Off. On. Off. Little more. On. Off. Let's see anteriorly how much you need to come on. Off. So we have come a little more anteriorly than usual to try and counter for that little deviation. Maybe I can take a little more of that bone inferiorly than what we usually do. So eustachian tube inferiorly, we start just above, on. Until you're on bone, don't move this cutter. Oh, sorry. Off. Just checking again that I have a little ledge here. On. Off. On. It's a little more tricky on this side because of that spur. On. Off. Okay, so that's my artery. Okay, maybe I can come a little touch more. On. Off. Okay, elevator. So, sorry, a second. So, to answer Narayan's question, if I want to reverse it, I will cut from here to here. And this flap will then come across the posterior septectomy and cover this bare cartilage if you've done a Haddad on this side.
Yes, absolutely.
थोड़ा वेट करेंगे आपको. Tissue glue hopefully we don't need, but keep it. So this side is a little more of a struggle. Similar to that side, we have a little sphenoid mucosa stuck to the flap. Give me a scissor, endo scissor. Ethmoid આપો ચલો. Okay. So my scissor work like a forceps. Elevator. Now this inferior incision is going to be a little more tricky to elevate with the spur. But I will not bother too much with it. So let's come this side. Dislocate cartilage from bone and elevate from this side. Now that I've taken my incisions. Clean. Give me a elevator. So here is cartilage. This is cartilage, this is bone. I'm going to be taking a little bit of cartilage as well here. You have cotton?
Yes.
Only because we have that little bit of spur and deviation which we want to counter. In other cases, we would not do this, okay? Okay, that's cartilage. Give me a scissor, strong scissor, moti scissor. This bone also we try and take out in an intact piece, or in at least a big piece. Okay, let's take our elevator. Give me an ethmoid. So this is the opposite side of the flap which we had not elevated. Ethmoid. So we have a nice piece of bone here if we want to use for reconstruction. We also have a nice piece of cartilage if you want to use for reconstruction. Okay, so you see a nice piece of bone. We had that cartilage piece somewhere. Give me the backbiter. Backbiter. Now what happens if you want to go more posterior and superior without affecting the olfaction? That was the cartilage which I wanted to take out. Now inferiorly we can also look and see if there's any major piece of bone that's remaining, which is here. So this is our posterior septectomy. This allows us now to work on both sides. I think if Hitesh is helping me, we may need to move the monitor a little bit. थोड़ा मॉनिटर ऊपर ले सो. So Dr. Hitesh is a lefty, so he's on the left side. and that means my monitor now goes more towards the head end, which usually is opposite, or because ENT and neuro are both on the same side. But today we'll see how it works. Okay. So now that these two flaps can be lowered, we have access to the whole anterior wall, right up to the keel. Okay, so left ostium, right ostium, part of the superior turbinates on both sides. I decided that I'm going to take that as well. So give me elevator.
So it looks nice, and this is what we call the owl's eye appearance.
Owl's eye, cobra eyes, witch's eyes. So I'm going into the superior meatus here, okay? Straight into superior meatus, and scissors strong. And we're just going to cut that bit of the superior turbinate, more or less at the level of the septum. Ethmoid. So usually when we do pituitary, I would approximate that 70% of our time is in exposure. About 20% or 25% is tumor removal, and 5 to 10% is reconstruction, because you're already doing the reconstruction as part of your exposure. Cottle. Yeah, नहीं तो scissor uply rotatable. Huh. So we have a little bit of mucosa there remaining on the scissor. अच्छा दे डिब्राइडर आपो चलो अच्छा अच्छे नहीं नवी इंस्ट्रूमेंट माँ No, I have a rotatable scissor. I had given him 6 new instruments. Tell him to keep all those instruments here. आप बड़े instrument अगल रखो. So we are not fighting.
So if there are any questions, we'll be happy to take it, okay, from the audience.
Okay. Give me holding. Somebody holding, please. No, come on. I'll tell you when to come in. So a little bit of bone there in that superior turbinate. We just want to take out. Give me ethmoid. Do we have a debrider blade? Just a 40 debrider? Before we start drilling. Hello? Suction. Okay, so that opens for us the left posterior ethmoid, which I will just take out a little bit more of the mucosa until we get the blade fitted. Give me an elevator. We'll finish it on the right side as well.
So, Nishit, there's a question. Tell us the limits of your exposure, okay? Superiorly, inferiorly, laterally, medially.
Yeah, so instead of limits, I'll tell you my comfort of my exposure. When the exposure becomes comfortable. Because limit is right to orbit. Elevator. So we do the same thing on this side. We'll go into the superior meatus, open up the posterior ethmoid. Scissor, please. Strong. Strong. When you make this cut on the superior turbinate inferiorly, you have to be careful of that flap. So I just slide it down. I'm watching the flap and then cutting. I don't want to cut the flap by mistake. Ethmoid. You can see the optic nerve there at the back?
Yes, we can.
Okay, so that's why I wanted to open these things, because there were some partitions there which I was not happy about. Give me the debrider. Where is the pedal? Okay. So on this side, I just wanted to open that posterior ethmoid a little better. Okay. So now I have a good posterior ethmoid. Okay. बराबर nothing. So now elevator. Supposing I want a little more exposure superiorly, then what I'm going to do, no, where's the earlier elevator, what you were giving me earlier? हाँ थोड़ा वेट करें नहीं आ नहीं बीजू आ तो okay I don't know where it's gone. Okay, so what I'm going to do is just elevate a little bit of this mucosa of the bone. Okay, so this mucosa then contains my olfactory fibers. So I want to selectively take out the bone without taking the mucosa. Are you okay? Give. And loss of olfaction is highly underrated, you know. It's a very important thing. So you want to take only the bone and leave the ostium, leave the bone, leave the periosteum behind with the olfaction. Give me ethmoid. So that's how you then just take out the bone but leave the olfaction behind. Okay. And then I would just fold this up a little bit like that. So now I have a much clearer view of my planum. Okay. Let's get a lux. So at this moment we can drill or we can just do this. Take a lux, bigger lux. You have a bigger lux? So this lux is not going to work. This lux is too dhila. I need a strong lux. With a nice strong lux, I can just break the whole rostrum and take it out in one piece. Biggest ethmoid, सबसे बड़ा मोटो ethmoid, मोटो. જેટલું મોટું હોય એટલું. Okay, I don't think we have a lux. We don't have a lux. Okay. So that leaves us with no option but to use a drill. Big?
Nishit, do you have an osteotome there?
Yeah, we have an osteotome. For the keel, we will use the osteotome. For the rostrum, we normally just lux it.
Yeah.
But I'm happy to use a drill also. Yeah. So this is the junction of the bone between ethmoid and sphenoid. And we want to take that out on both sides. And I'm also going to take out all this mucosa. Give me a osteotome. Maro. Okay. Insulated suction, sir. So I'm going to come back, Narayan, to your question of exposure once I can see inside better.
Sure, sure.
So that's a big piece of the keel. Wash. Wash. Warm saline as usual.
Yes, sir.
Okay. Okay, thank you. Okay, because we have a well pneumatized sphenoid, we should also be able to see our anatomy well. Okay. So now we will start peeling off this mucosa and see, try and see the anatomy better. We can remove mucosa like this and leave it attached laterally to form a mucosal flap, which you can use at the end of surgery. But I think it just consumes a little more time in trying to preserve it during surgery. So come in with suction. So I'm not going to bother too much doing that. Inferiorly, we'll see we don't need to remove all the mucosa. So if I'm going to use a flap, then I have to remove all my mucosa. If I'm not going to use a flap, then I don't need to remove all my mucosa. Okay, sometimes the mucosa just helps and comes out by itself. So that's our mucosa on the left side. We have a little bit remaining at the inferior part, but I don't think I need to remove that. These are some of those incomplete septations that we saw. Also one at the top.
So sometimes you get a lot of oozing at this step. How do you handle that?
So this oozing happens because this mucosa has no venous blood supply. So it drains straight into the bone. So when you strip it, you will always get some venous oozing. Warm water irrigation, patience 5 minutes, it will usually stop.
Yeah.
So our one side sphenoid was smaller, right? So that's our mucosa on the right side. Wash. Okay, thank you. It might.
Yes, sir.
Move. Hold it on top. Just hold it. So this sort of working together as a team comes with a little bit of practice. And you should not get frustrated because in the beginning it is little difficult. And then it becomes easy. So we have good mucosa on both sides if you want to use as free mucosal grafts at the end of surgery. Now we have an intersphenoid septum which we need to take. Give me this thing please, ethmoid again. And let me clean my scope. We need a kerosene punch. This septum goes towards the carotid on the right. Yeah. Cleaning. Cleaning. Take a pause. Okay, so now Hitesh Bhai has come in with his suction. So we have the moment at least a 3-hand, and when we need to drill, we'll have to change to 4-hand. So that gives me a clear view of the carotid on the left, okay? So this is clival carotid, and I'm just going to take this mucosa so that we are well oriented now. Okay. So we have carotid on the left. On the right side, the carotid, I still need to see. I need a punch. Punch, kerosene punch. Okay, so let's widen this opening. So right now I have a little bit of a triangular opening. I want to make it a little more rectangular. Little vision, please. Okay. Try and stay below me so you don't come in my way. So I'm taking out some bone on the side so that we have clear views on the side, and more important, we have easy instrumentation. Come a little superiorly as well. So we saw there was a little cell partition there at the top. Ethmoid. And this is why I needed to remove a little bit of cartilage and bone, sorry, not cartilage but bone in this area.
So you can see that what he's doing is he's trying to get exposure of the tuberculum and part of the planum as well. Inferiorly, he'll remove that rostrum right up to the floor of the sphenoid. Okay, and similarly laterally, you should see more than the carotids. You should see the lateral wall of the sphenoid. Right, Nishit?
Yeah. So my straight instrument, my straight ipsilateral instrument should go to the carotid easily, not cross. Straight instrument should go to the carotid easily. Then I have a good exposure. At least 2 suctions under the sella and a glimpse of the planum. Clear views of the optics. Then I know my exposure is adequate. Okay, punch again, change side with the suction. Okay, I need to widen this part. Yeah, so Hitesh Bhai is going to retract the flap for me while I take out this bone. Clean. We have the optic nerve just above us. Give me another suction. Okay,
Nishit, can you wash the field?
Yeah, we're just doing, I want to ask for another suction. So this is the septum that goes towards the carotid on the right. So that we want to punch. We don't want to hold and twist as we go posteriorly.
Yeah, safer bet is always a drill. Safer bet is always a drill. Drill out all the septations.
Yeah, we have to take out all the septations for 2 reasons. One is to allow for easy instrumentation, and 2 is for any reconstruction, that it sits on a flat surface. Okay, so now we have a very nice view of the carotid on the left as it comes up. So clival carotid, cavernous carotid, clinoidal carotid. You have optic nerve above, and you have the OCR lateral to my suction. On this side, again you have optic nerve here. You have the carotid artery here. OCR is under this septum, so not that clear. But you have the clival carotid here now in vision, and it's coming up here as the cavernous. So we have the sella now in good view. And give me the punch again. And shortly we can start drilling. I think I lost that bone. Okay. So now we have a really good view of our planum as well. Okay. Okay, so our exposure is good now. Now, if Hitesh bhai will hold the endoscope and do irrigation, then I can drill. So I'm not used to this because usually my neurosurgeon's on the left side if he's a lefty. Debrider. But we'll see how this goes. Now fortunately we have a micro debrider hand bore, so actually I can do everything on my own. I can hold the endoscope and drill on my own, which might be a better option to start with. But તમે irrigation અને suction વાપરો. हाँ, give it to Hitesh only. તમે irrigation પણ કરો. You are both in the same nostril. Suction here. So I'm just knocking off this septum a little bit over the carotid. Okay, so now I can see that carotid even better. Show me right carotid. Right carotid. Down. Okay, so now you can see the right carotid very clear. Okay, which is lateral to his suction. Okay, so let's go with these septations. Just above my drill is the clinoidal part of the carotid. So again, as Narayan said, I'm just flattening the septations first. Optic nerve there. Coming on to the left side, median OCR. And we can start taking the bone of the sella now. More water in the irrigation, in the drill. Okay. Let's do the same thing on this one. So we have a little exposure here of the cavernous. So there are two parts where the carotid is close by. One is at 5 and 7 where the clival becomes cavernous, and then is at 11 and 1 where you have the clinoidal part. Water. Okay, it doesn't matter, you irrigate. A little bit of tough bone in this area.
हेलो
Yeah.
हाँ मैं दिखाना
Sir, kindly show the full course of carotid right from the Vidian canal to sphenoidal segment.
Vidian canal is not exposed and is not required to be exposed.
Okay.
So we've exposed the palatovaginal on both sides. But
Yes.
you see down is the clival part of the carotid where my drill is. Can you see this bulge? Left carotid.
Yes.
So this carotid then becomes a cavernous carotid as it forms a C around the sella, and then here is the clinoidal part of the carotid.
Okay.
Okay, same thing on
Okay.
the opposite side.
Clival. Cavernous. So drill up to the egg cell thinning of the bone, right?
Yeah. Give me you have a disc dissector kind of thing?
The field is very good. Anesthetist is doing very nice job.
Of course. When the field is not
Round of
good,
applause for anesthetist, please. Dr. Loria.
any fine dissector there? You know, I took one instrument. Let's try this. Okay, so let's see if our bone is ready to come out.
Very nice, sir.
Very nice,
Round
sir,
of
very
applause
nice.
for you also, sir.
Thank you. So when the field is not good, we blame the anesthetist.
Yeah, nature.
When the field is good, we must appreciate.
Sir, which incision do you prefer over this tumor?
So I work normally with about, 10, 15 neurosurgeons, and each person takes a different incision. Now, Dr. Milan is here. So Milan is going to now direct the whole surgery from here on. I am only going to follow his instructions, because from the dura point of entry, I will continue surgery only if Dr. Milan requests me to do it. Otherwise, so if I have permission, then I will go ahead.
Written consent.
No, not really. I mean, it might. To do this surgery, the most important thing is to be friends with your neurosurgeon. If you and the neurosurgeon are not friends, you can never be a team. At some point, after doing 5 cases, you will start fighting. I want to do more, you do less. I want more money. Block,
So
suction block.
this, Nishit sir, Delhi, Gurgaon, it has already happened now.
Where?
Delhi and Gurgaon. So neurosurgeons learned the thing and now they don't call us.
Yeah,
Not
no,
even
it's-
for the septum work also. These guys are doing everything.
So you see, this happens everywhere, not only isolated to Delhi, Gurgaon, everywhere. We have seen, in Bombay, that same elevator dissector, there are only 2 teams which have functioned well for a long time, despite there being, 500, 700 ENT, which is Dr. Narayan.
Yeah.
It's the neurosurgeon expects that he will do the pituitary and call you for meningiomas, craniopharyngiomas, where you need a adult flap and it's more complicated.
Yeah.
Now, if you have not learned to work together in simple cases, how are you going to suddenly work together in difficult cases?
True.
It's not possible. And then there is fighting, there is a complication, and the team breaks, because each one will blame the other person.
Instead, it should be the, it should be the liability of both the sides. They should accept it.
So I've got a little blue on this side, cavernous, and I think I can see blue through this, so I'm not going to do any more. I think we are okay.
Yeah.
Okay, let's get a knife. Chalse, whatever you got. So we'll take an incision I'll elevate this flap and then I'm going to hand the scope to Hitesh so I can try and work with 15.
Sir, there is a question from the audience. Do you prefer to cauterize the surface?
Beforehand?
Yes, sir.
Not really. But we have a bipolar attached so that if there is bleeding, then we'll cauterize. Yeah.
He is U-shaped incision, I guess. He is comfortable with it.
I think we have a little bit attached at the bottom. And you can, down also. Maybe a little bit here. Give me the dissector. ले हाथ में ले. So we'll elevate this flap. And often you get CSF leaks in this area. So this flap is to try and protect that from happening. Okay, you can also get a thin layer of pituitary. You see this above the tumor. So you can try and peel that off, but here it's too thin for us to worry about. We need this thing. But you can make out the difference, right, of the pseudo capsule. Okay. Except for biopsy. Hold this. Okay, let me just try with 2 hands now. Let's see if we can manage. ઉલટું છે. Give me the forceps, please. Yeah, Hitesh, I want you right up, but right up against the top.
You want to see? Sir, can you ask the cameraman to show the external arrangement now?
Yeah,
How you are
8-point
holding the
forceps,
section and
normally 8-point
cameras,
forceps.
positions of the assistants.
So we'll just get some biopsy done here. Biopsy. You got biopsy?
Yes, sir.
It's very soft, this tumor, okay? So if it's a little firmer tumor, I would have tried an extracapsular. But once it's such a soft tumor, I don't see the advantage in doing an extracapsular.
Sir, do you prefer double suction method or ring curate?
Yeah, we'll use 2 suctions.
Okay.
So now I think we got enough biopsy. We'll take a second suction. Okay. So Hitesh, see your scope now is coming down. Scope has to be up. Yeah. And your hand. Also, I want this cable to go there.
Sir, so audience want to see the external picture of
I have
arrangements.
this fully open.
Hello? Hello?
Okay. Yeah. I don't know where the audiovisual person. Okay. Come little closer. Yeah, it's good. So first we will start with the inferior part. Once we finish with that, only then we'll go laterally. Okay. So I'm going to just get a little change done here. Hitesh, you will come in from this side. From this. Oh, you. So my right hand is my more dominant hand, and that's clashing a little bit with his with the endoscope. So I'm going to request him to come from this side. Cable upar lai lo. You want to hold with this hand? Are you comfortable with this hand? Then your hand doesn't come in my way. Ah, beautiful. This is perfect. And irrigation with the other hand. Okay, come out a little bit so I can see.
Sir, there is a question for neurosurgeon, sir.
Then irrigate on your
When
scope.
does he prefer to use
Come
KUSA?
out. Irrigate your scope so I have vision. Hello.
Hello. Hello.
Hello?
Irrigate.
Hello?
Yeah.
Okay.
Yeah, we can hear you.
Sir, the audience want to see the external arrangements.
Asha, somebody take a photo.
Before removal of the tumor.
We'll take a photo and put it on the group. Okay, so everyone you can see that. Who's here who can take a photo and put on the group?
Okay.
Or you can take video also and put on the group, I don't know.
Sir, the question for neurosurgeon.
Wash. Wash. Wash on the same side as the scope. Yeah.
Hello. Nishit sir. Sir, people wants to know
Bas,
when
bas,
a
not
neurosurgeon
continuous.
prefers to use KUSA.
Dr. Milan. Give him Dr. Milan a mic, please.
Pardon?
They want to ask you when are you going to use a KUSA? No, don't irrigate unless I have no vision.
What is the question, sir?
In which situation will you use a KUSA for pituitary surgery?
KUSA.
KUSA.
Sir, pituitary, for pituitary surgery, if the tumor is soft and gelatinous, it will not require. But if the tumor is firm, then
Your voice is very low. Keep mic closer.
What he's saying is, when it's soft, you don't need it. Only in certain situations, if it's very firm, not suckable, you are finding it difficult with the curette, then you want to consider using a KUSA. Does that answer it?
not require.
Sir, what is the power of suction, and is the keyhole is closed or open?
No, right now the suction power is a little less for me, because the better the suction power, the better the suction, and I can control the power with my keyhole. So we're trying to finish the left side off first. Hoi, 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 hoi. No, so our image is now rotating, which is not a good thing, so I'm losing my orientation. Okay, no, this is not working, so let's try it this way only. See if you can hold it from here, from this side. You hold it from here.
Hello?
Go up. Stay here.
Hello? Nishit sir?
Ji.
How can you ensure tumor is completely removed? By any
so
landmark
will
you can come to
irrigate
know?
on the scope.
It has completely removed. There is no residual tumor left.
Yeah, so we must see the diaphragm and the walls of the this thing, cavernous sinus.
Okay.
No, on the scope. Yeah, I know, but it's not in my control. So these are some of the issues that you face when you're working together for the first time. So I mean, you can't help it. You just be a little more patient, and sooner or later we'll figure it out.
Hello?
Okay. So once you have a clean image, then don't irrigate. So once you have an image like this, then don't irrigate. Little more inside. Yeah. So on the upper part, we are now beginning to see a little bulge, right?
Yeah.
Okay. On the right side, your camera is tilting. Yeah, a little more. Again, I don't want to lose my 12 o'clock orientation. That's very important for me. Okay. Is that 12 o'clock orientation. Also, because we are working for the first time, I'm little fighting here to use my left hand, which I'm not able to do effectively. But now you can see on top there is an arachnoid layer coming in. Right? So
Yeah.
at this point we have a risk of a CSF leak. Clean scope. Okay, I think I'm just going to try with a little bit of, I'm not getting the vision I need to see. We are going to try and see if I can manage like this. Okay.
Sir, in case of supracellular
Nitesh,
extension or
Reconstruction.
extension lateral to the carotid, how will the management differs?
Sorry?
In case of supracellular extension and tumor encasing the carotid
Just stay down,
completely,
okay? Stay
how to
down.
manage?
No, stay down. Stay here. Yeah, just stay there. Don't try and do any dissection. If there's any blood that comes in your field, just suck it. Otherwise, keep the keyhole open. Okay. Now, with the keyhole open, just gently retract the diaphragm. Very good. But no suction. Just using it as a retractor. So we have some tumor here at the bottom. Okay. So once the whitish thing gets over and you see a little pinkish, okay, you
Yes,
see a little
yes.
pinkish on the right side,
Yes, sir.
that's normal pituitary.
Okay.
We don't want to take that away, okay?
Okay.
Lift this corner. Yeah, little gentle. I want a patty with only saline, please.
Without adrenaline, sir?
So I think we are now more or less good with this part. Let's go across and see this side. Again, elevate. Come here and just push this diaphragm up. And you can see now we got better coordination. Okay, let's stop it. Little bit of tumor on the top here. A little bit of tumor on the top, which we're just taking suction out. This is dangerous because here I can get a CSF leak. Okay. Come in, hold this. Come in from your side. Yeah. No. Come out a little bit, just hold what I'm doing. See what I'm doing? Just hold the tumor like that. Huh. Give me a curette, please. Okay, wait, come on. Savlon. Curette, 45. Not very big. So for the first time, we'll take a curette and see if that helps us a little better. Stay in with the suction. At the bottom, stay bottom, 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 bottom. Bottom. You have a bud. You have a bud. Okay, you can see there's quite a bit of tumor there which was stuck to the diaphragm. And you also see I'm using the curette in an opposite direction. Okay, I'm not using it. So this is like an extra capsular.
Yes, sir.
This is off that cavernous wall now. Just hold it down, yeah. Hitesh is, of course, also experienced, so that makes a big difference when you have a person who is experienced in pituitary helping you. Okay, very gentle suction inside. I'm holding it, you come in with gentle suction, half suction. Yeah, staying there. Half suctions.
Superbly removed, sir, from the superior surface.
Okay,
Great,
one
sir.
minute, come on. Yeah, I
Ali.
just need a patty now to
Round
use
of
a patty.
applause for you, sir.
Backing forceps. So we have still got a little bit more to do. Let's try and get a patty in and a suction bane apo. Where's the other suction?
ये मैनुअल में कम करते हैं.
You keep this, I'll take this. But stay out just now. Just now stay out. No. So we are using the suction as a dissector with only a partial suction.
Yes.
And you can see now clearly the diaphragm on top.
Yes, sir.
Curette again.
Ossiculoplasty.
Same curette.
Ossiculoplasty. Ossiculoplasty. P-ossiculated rectum. Ossiculoplasty પછી DCR ને પછી.
Sir, there is a question. How do you deal with the residual mass?
How do I deal with the
residual tumor mass?
Residual tumor. So you have detected it much later, after 3 months. So that's my whole extracapsular dissection. Okay.
Wonderful, sir.
Very
Wonderful.
nicely, sir.
Holding.
Wonderful.
Sigmoid.
Big
Super,
round of
sir.
applause for you, sir.
Thank you.
Pulsation.
મેનુ આપણે નથી કરતા હોતા. આ મેનુ આપણે નથી કરતા.
Thank you. Yeah, tumor. We'll just look inside again. Patty, please. Packing forceps. We'll do one check again and see all the borders. There's some tumor at the bottom. Upper suction. Yeah, hold it. Suck. Suck. So you see what Hitesh is doing? He's dissecting the tumor for me. I'm just holding it. So I'm not pulling it. He's just dissecting it where it's attached. Okay? Holding 1 minute. Just hold it again. Okay. 1 minute. Slipping from this. You have another ethmoid, is slipping. Just hold it till I hold it. Okay. Now dissect. Go back in. Dissect. Okay. So that's the rest of the tumor out. Now give me a packing. We'll just check that part. Give me a curate. Yeah, I just want to check that. Exactly where the suction is. We'll just check that part if there's any tumor remaining. Okay, so there was some tumor there. Suction it. Yeah, take it. Take it out. So we have still a little bit of tumor here. Suction. Thank you. Okay. So now I think we are clear. You can see the right cavernous wall. Okay? So that's the impression of the carotid. What you see here is the carotid. Okay? As it comes from here and comes anterior to become the cavernous, you see it horizontally in the cavernous wall. That's exactly lateral to his suction. This whole thing is the carotid. Up is the diaphragm, and let's look laterally. Little tumor here, if you can take this.
So how much Doppler will be helpful?
How much?
Doppler will be helpful.
Yeah, if you're going to go around, or if there's tumor around the carotid, then you want to know where you are. If you're going to incise lateral to the carotid, then
okay, sir.
Otherwise, in this case, no. Apithema is normal suction. Okay, so you see the whole wall on the left side now?
Yes.
This is the cavernous wall and the impression of the carotid.
Yes.
If I put a Doppler here, you'll get a top. You have a Doppler?
Very nice, sir. So now, how will you reconstruct, sir? What is the plan?
The plan is not to reconstruct. So that is the advantage of not getting a CSF leak.
Yeah.
Is we just put a little bit of gel foam in here.
Okay.
It's not a very loose, thin arachnoid that you're seeing where the diaphragm is. If you're scared about an empty cellar, then you put a little bit of fat in there.
Okay.
But if you have a nice tough one like this, then it's okay.
Right.
So what will happen now is my two flaps will come back together. And then 3 years later, if the patient gets a recurrence, Hitesh Bhai can take a flap. It's saved. I've not taken it out and use it for reconstruction. Because in a revision surgery, he's more likely to get a CSF leak.
Yes, sir.
You want to induce the next case? We are more or less finished here. So I'm just going to give a couple of washes and then we'll check, okay? So also this is a good way to check is put a patty inside and look. Okay, so you can see the lateral wall clear?
Yeah.
Right? I'm also going to look at that corner at 1 o'clock and 11 o'clock. Clear?
Yes, yeah, superb.
Look at this side. Okay, cavernous wall clear?
Yes, sir.
Maybe a little tumor at the bottom. Yeah, you can check. I mean, you want to just see what it sounds like. Okay, clear?
Yes.
Okay, so there's no tumor there. There's normal gland in that area. Okay, clear?
Yes.
Sir, at the end, do you ask anesthetist to do the Valsalva?
If you are suspecting a leak.
So can we see it this?
Sorry? Okay, so at the end of this, I can take out my patty. You can see good pulsations, right?
Yes,
if
sir,
you
wonderful.
see pulsations like this, you don't have a CSF leak. And you can see normal pituitary gland stuck there. Okay?
Yes, sir.
This is all normal gland. You want to save the normal gland. I'm going to take my flap and put it back. Okay, a little bit of gel foam, please. Packing. पैकिंग फॉर सकते सर एक छोटा पीस देना हाँ ये चलेगा चलेगा हाँ नहीं चलेगा So I'm just going to put one piece of gel foam in there for hemostasis and also to hold my dural flap in position. And now I want big piece of gel foam. Big. No, give me the whole gel foam. सबसे बड़ा नहीं full
Sir, what are the different methods of reconstruction? Audience asking.
Well, you can do a free repair. You can put a fat. You can put fascia. You can put mucosal flaps. You can put nasoseptal flaps. It's unlimited.
Okay.
At the end of the day, you do what is comfortable for you.
Okay.
I'm just going to put a piece of gel foam here. Okay, so I have a nice big piece of gel foam which will cover the defect.
Right.
Okay? Not go inside the defect because gel foam can swell up. So inside you don't want to put too much. You just put that small piece.
Okay.
Okay? And outside I can put a bigger piece. I think we are finished. Huh? Or you want to still check? It's okay. I think we are done.
So,
Reva de? No. No, don't check because... No, आवाज नहीं.
so you are going to reposition the flap and suture it?
Reva de. I don't want to put this into...
Hello?
Because if it's touched his hand, that is not sterile. Then I don't want to go in there.
Hello?
Okay, our Doppler is taking time to figure out, so I'm just going to close.
So you are going to reposition the flap back and suture with catgut?
Yeah, I'll show you what I'm doing. Give me a pad, gel foam. Half karo. No, don't take any suture.